Thank you for joining today's webinar, Implementing and Sustaining Rural Community Paramedicine. This webinar will review the findings discovered in the February 2021 Rural Community Paramedicine Summit. Learning objectives for today's call include identifying the challenges and opportunities related to implementing and sustaining CP in rural communities, recognize key strategies and lessons learned from participants of the February 21 Rural CP Summit, as well as provide examples of state flex programs that can support related initiatives to support rural CP. Additionally, I would like to highlight a few upcoming task events. There is a telehealth webinar series. The monitoring of rural patients will be on July 7th at 2 p.m. Central Time. Registration is now open for the 2021 Flex Program Virtual Reverse Site Visit, and that will be held July 20th through the 22nd. The telehealth webinar series will continue with Rural Telehealth Behavioral Health, held on August 3rd at 2 p.m. Central Time as well. With that being shared, I'd like to welcome Nicole Clement, the Program Specialist on the task team here at the National Rural Health Resource Center. Thanks for joining us, Nicole, and I'll now turn it over to you.
Great, thanks. Hi, everybody. I'm going to just switch slides here. Take me 1 second. Are you guys seeing them full screen? Just the slide, nothing else?
Right.
Okay, perfect. All right, thanks for joining us. As Kiona said, we are here to talk about implementing and sustaining rural community paramedicine. Our standard slide talking about who we are at the center, a nonprofit organization dedicated to sustaining and improving healthcare. The center focuses in 5 core areas, so transition to value and population health, collaboration and partnership, performance improvement, health information technology, and workforce. So the information you're going to hear from us today is all based off of an event that we held in February of 2021, so just a few months ago. The event was held virtually, supported by the Federal Office of Rural Health Policy and coordinated by us here at TASC. The objectives of the summit, the things we were hoping to accomplish with that event, were to identify the challenges and opportunities related to the implementation and sustainment of CP in rural communities, identify established CP models and capture some of their lessons learned, identify strategies and resources, both existing and needed, including how state flex programs can support related activities, and then also to talk with that group about the future of rural community paramedicine. These are our summit participants. We didn't list our center staff on there, but that was Terry, Kiona, and myself. We have this mix of participants, and so we chose those listed on the slide as participants for different reasons. There are some well-established CP programs there that include a mix of urban and rural focus, a critical access hospital administrator with an in-house CP program, and a couple of flex programs that have been implementing CP for a few years now, and also representatives from the flex monitoring team at the University of Southern Maine who evaluate flex-funded EMS and population health initiatives and have also done work around EMS data and measurement in past years. So with that, Terry, I'll turn it over to you to talk about some of the opportunities that this group identified.
Yeah, thank you, Nicole. And I should say, as a little bit of background, we've been doing these summit meetings for the last, it's either 18 or 19 years. And it's just been a process of convening a group of experts, folks that are representing the state flex programs, again, as diverse a group as we can gather. And we thought this particular group was particularly engaged and really produced what I think is going to be a really great report here. So what are the opportunities for rural community paramedicine? And I think COVID recently has basically highlighted a good many as we look at patients kind of staying in their homes, staying out of the emergency rooms, out of the hospitals if at least possible. And that really gets into one of the core pieces of community paramedicine, and that is care coordination, community care coordination in particular. And those sorts of things include paramedics going into the home, let's say to do medication checks. One of our participants, Jonah Thompson, who works for the Allegheny Health System, indicated that they had been doing medication reconciliation, literally they've been doing it for years. And he said in the vast majority of cases, close to 80–90%, they find that the medication basically needs to be changed, needs to be revised, et cetera. So the community paramedic may not be doing that, but they will have a liaison then to a pharmacist, and the pharmacist will be able to do that, and the community paramedic will be on site and help make sure that the patient is presenting the medication, et cetera. So that's a really big thing. Another thing that they can do is they can look from a 360 view of all of the social indicators of health and safety issues. They look to see if the rugs, for example, are going to be stable and not be conducive to falls. They may check the refrigerator and make sure that there's enough food to eat. They're looking at a variety of different things over and above just the medical side of it. And that, that function has become extremely important, again, as COVID has dramatically increased the number of patients that are being treated in the home, and as telehealth is also expanding appropriately as well. And then there really is a systematic way to bridge gaps. And one of the things that has been most problematic in terms of bridging gaps has been the transfer of patients between acute care and long-term care and/or home. So, the post-discharge follow-up is something really made to order for community paramedics. They also bridge the gap between the patients in their home and the primary care physicians and the primary care providers pretty much in general, so that they can ensure that the patients are in communication with the primary care docs and the nurse practitioners, the PAs, et cetera. And also this has given us a way to actually use telehealth a little more significantly here. And actually, many of these community paramedic programs use telehealth in the home in that bridging of the gap. It's kind of a field version of case management as well. So we got stories coming from both rural community paramedicine programs, some of the larger community paramedicine programs. We couldn't find anywhere that had actually collected a ton of data that was just all rural. But what we found is some of the real urban models have expanded recently out into rural areas. And the data that they've collected has been really very significant, very impressive. And we'll talk a little bit more about that as we go along. We also think there's some potential new funding streams as well. And this is going to get back to this need to show value, because the payers who have been reluctant in the past, perhaps to pay for community paramedicine, one of the biggest obstacles that stands in our way here, are starting to see this as perhaps a way to reduce costs, to prevent hospital readmissions, and et cetera. And we're seeing Medicaid programs that are taking a hard look at this. Some are already opening up in that area. So we think there's also some potential new funding streams out there. And then the third piece here is the ability to demonstrate value. We are moving as a country into value-based payment, into population health payments as well. And that also represents an opportunity for new funding. In other words, the data is pretty clear. I'm on the board of the National Rural Accountable Care Consortium, and I've had access to the data that shows that emergency medical services, the overuse of emergency rooms, et cetera, has consequences both from a financial standpoint and a quality standpoint. And really, there's whole issues of inappropriate ER usage as well. So one of the prerequisites, though, for that value funding would be really having the data available to demonstrate value. And I guess our folks kept hitting this particular issue again and again. It's like from day one, we need to start getting this data, because the data that we do have, the data that the Allegheny Health System has, the data that the East Florida Health Council has, et cetera, really indicates the value. It's at a lower cost, and it's providing outstanding care to the patients and very high quality. And as we talked about before, it also enhances the whole continuity of care piece as well. Another piece that was recommended is that the community paramedicine program folks said the data is great, and you really need it with your payers, and you need it with policymakers, et cetera. But they really emphasize, don't forget the storytelling. There are a lot of stories here of patients, COVID patients in their home, where the community paramedics have been a godsend, have really helped, have been able to do things that home health providers cannot do, have served as that bridge between the medical providers and the patients and the families, et cetera. So they said really collect stories as well as the data that you're collecting. Yep.
And I was just telling John Supplet in the chat that the document is on the website, and we'll provide a link to it in a minute. There's a full documented summary of this event and what we learned from our participants. And there are definitely some stories that are told in much greater detail than we're going to be able to get into here. So we'll be sure that you guys get a link to the document.
Next slide. So there are also a number of challenges for rural community paramedicine. At the top of the list, as always, is reimbursement and funding streams. Our hospital administrator, who had been basically operating a community paramedicine program for years, said, it's not really paying for itself at this particular point, but I'm championing it, and we're not losing a ton of money on it, and it absolutely is improving the care that is being provided. He said it's improving the image of the hospital as well. And I've already talked a bit about, Medicaid funding, making sure that Medicare is funding this. And then if you've got the data and, we have an argument to the private insurance organizations as well, those become very important. Workforce challenges. One of the things we learned is that a community paramedic isn't necessarily, may not necessarily want to do this sort of work in the home. They basically went into the career because it was an exciting way to help people, in emergencies, in the ditch, et cetera. And so it could be that you can't just say, we're going to take our community paramedics and make them, good, or the paramedics and make them great community paramedics. In many cases, you may have to hire specifically for this sort of a role. There are also various training. It tends to vary by state. So at least at this particular point, there's not any national standard for the training itself. So the workforce challenge in one state may differ slightly from other states as well. But just getting an adequate supply is another thing we heard. Just again, I think this is a great opportunity for basic ambulance services potentially to upgrade to community paramedicine, or for paramedic services to expand their role and to become more financially viable as well. Leadership challenges, was mentioned as well. If you're going to be operating community paramedicine out of a hospital, for example, you're really going to have pretty strong support from the CEO of the hospital. Leadership has got to be on board here. I would say medical leadership as well, that physicians, nurse practitioners, PA need to feel that these community paramedics are part of the team, and that they're going to be providing medical care appropriately as needed. And then the whole concept of leadership, et cetera. Nicole and I were on a meeting we had just yesterday where we talked about the real need for leadership support and leadership training in emergency medical services pretty much in general. There are business skills that are required here. There are personnel management skills, et cetera. And so again, as we think about, if we're thinking about getting into community paramedicine program, thinking about how we recruit leaders, how we train them, how we support them moving forward. And then another challenge is just, we have a lot of anecdotes out there. There's a lot of thoughts and kind of promises for community paramedicine, but the lack of data inhibits that ability to show value. So you're going to hear both Nicole and I hitting on this data drum, kind of repeatedly, that if we don't have that data, that our payer support simply may not be there. They're going to ask for hard evidence that if it's paid for, that it's actually going to provide value, and that means it's going to be cost effective, and then secondly, it's going to contribute to both patient satisfaction and better quality as well. Anything to add to that, Nicole, before I think you're going to take the next slide.
Yeah, like Terry said, you'll hear us mention data again. It came up in every level of the conversation that we had with the participants. And, not only is there not pre-existing data that is telling payers how fantastic CP is and the outcomes it has had. I mean, there is some, but also just being able to use data is a big issue. We all know rural ambulance services and data reporting is a struggle. Some of them do it and do it well. Some of them do it. And I heard from a project just yesterday that they're realizing data quality issues as the reporting is happening. And I think that happens probably every single time you start a new data initiative. So knowing how to use the data, knowing where to find the data, knowing what data to gather, there's a lot of issues around data. So yeah, you'll hear us talk about data repetitively throughout this presentation in a different context. So Kiona pasted a link to the document in the chat, so you guys can check that out. Like I was saying, that document will go into way greater detail than we could on a 1-hour webinar, so definitely check it out. Just moving on to key implementation strategies. When implementing a new CP program, start small and focus on an identified need and do that really well. And then build the capacity to do more. Be really careful not to take on patients that the CP program isn't equipped to deal with. Trying to do too much can cause the program and the program staff to become overwhelmed. So they might end up doing a lot, but not doing it very well. Partners are important in various ways to CP. Be sure the stakeholders understand the intent and focus of what you're trying to do with your CP program. Have a compelling business plan and metrics that matter to you, of course, but also to whoever is going to be involved and that you're asking to invest in the program. That was one point made in the guide, is that the traditional EMS metrics are not necessarily going to be what your potential payer is going to care about. And there's definitely a section in the guide that gets into different potential payers. It might be a fee-for-service payer who's going to care about making money. It might be a value-based payer that is going to be interested in prevention. Like, those are two very different payment models if you think of it. So definitely check that out in the guide. And also, those community partnerships, they're vital. You want to make sure that you have synergy and that you're not duplicating services, that everybody's on the same page with who's doing what, and there's not any disagreement or misunderstanding about what your CP program is trying to do. Differentiating the CP program from other providers is also important so that patients know exactly who's caring for them in their home. One of our summit participants shared that they created a care map for patients and clipped their business card to it so that the patient knows that they aren't home health, they're not a therapist or some other sort of provider. And then, remember a second ago, I was talking about data and how we're going to bring it up over and over again. So here it is again in the implementation strategies. Show value through data and outcomes. And again, consider the data that matters to whomever you're talking to. Who are you trying to get to pay for these services? And collect and analyze that data. Be sure you're having the intended outcomes, and if you're not, why not? And then address those issues, and that is not only going to help your implementation, but it's going to feed directly into your sustainability as well. And then the last one, take advantage of the current COVID flexibilities. They've emerged to fill gaps in the healthcare system, and while the public health emergency obviously won't last forever, some of those flexibilities may remain, such as expanded scopes of practice and telehealth opportunities. Our summit participants definitely saw the opportunity to be joining telehealth pilot programs right now.
You know, and we also know that we're moving very steadily and very quickly into care at home. There's the whole hospital at home program, which is expected to expand significantly here. We're anticipating that folks are going to be able to be cared for in their home, perhaps as an alternative to long-term care facilities, et cetera. So as we think about this, the need for medically trained, kind of healthcare background sorts of paramedics in that home is going to enhance the spread of these sorts of concepts. That it's just not enough to have a home health worker there if we're going to be providing this sort of care. And I know that the Mayo Clinic, for example, really sees this community paramedicine as a big part of their future. They have a number of different demonstration projects going on, and they can already envision kind of this hospital at home expansion, and they see community paramedics as a means to do that safely as well. So
yeah. Go ahead.
These are the key sustainability strategies that we heard from, and plan for sustainability on day one. That was one thing that Ken Peach from East Florida just strongly advised, that if you're going to be getting a grant, you may have 3 years of funding, you may have 1 year of funding or whatever, but that's not really a sustainability plan. That the time, and we find this with grants so often anyway, is that by year 3, you're thinking, oh, damn, we're gonna, it's gonna run out this year, what are we gonna do? And so starting at the very beginning, thinking about, okay, I'm gonna have to get the data, I'm going to have to approach other funders, I'm going to have to reach out perhaps to, is there an accountable care organization around that I can make an argument to? Will the community support this? Again, with the community, you want to have the stories in place and be able to talk about that as well. And again, in yesterday's meeting of the EMS grantees, We really went through an entire community process that can be used by EMS. Again, it's a, you know, EMS is dramatic. There are ample opportunities to speak to community groups, and it's really hard to be against emergency medical services. It's a popular service, but you got to get out there and you've got to engage the community leaders. Identify those new and continuous funding streams, again, from day one. And then just because we haven't mentioned it on this slide, we're putting focus on the data, because that's going to be you know, something that the payers in particular are going to want to see. Next. So these were some of the lessons learned, kind of a page full here. And at the top of the list, and we really want to suggest this, if you're thinking about starting a program in your state, or if you've got a hospital that really wants to start a program, don't reinvent the wheel. One of the great things about working in rural health is everybody's willing to share. And we have some really great community paramedicine programs out there. You know, Ken Peach, for example, who's a former hospital administrator, which gave him a huge advantage in terms of thinking about, okay, what, you know, how do I show value to the hospitals in my region? But, you know, he's more than willing. He shared a number of different data collection tools, how he monitors the funding that's coming in. And virtually everybody said, hey, we're totally willing to share everything that we know, all of the tools and resources we've developed. And again, this is just something, task was created because we didn't want states to be in isolation from each other, that what's going on in California needs to be shared with what's going on in Maine and vice versa. So, and do come to, you know, at the center, we are collecting tools and resources. I know RHI Hub has a good deal of materials, et cetera. So just don't reinvent that wheel. Seek partners where you can make an impact. And again, if you have an ambulance service that's looking to become a community paramedic program, reach out to the hospital. That's just such a natural ally here. It could very well be if the hospital is in an accountable care organization or is in a global budget situation, that they're going to see some value in kind of reducing these costs and, you know, reducing the use of the emergency room, the hospital readmissions, for example, where, you know, if they're a DRG hospital, rural hospital, they're going to get fined for readmissions, and readmissions are important, but which is my next point here. But do reach out to that group. Go to the senior centers. Look at perhaps partnering with other ambulances or hospitals in your region. And so we really think this partnership, you know, partner with your community, you know, see if there's anything that can be done with the schools, the long-term care programs, et cetera. So partnerships were something really advocated here. But don't make preventing hospital readmissions your only focus. They are of great value to hospitals, particularly those that are not critical access hospital, because, you know, they're going to get fined if they have high hospital readmissions. But there's so many other things to be looking at, and one of them is just the entire social determinants of health. This is really an opportunity to deal with chronically ill patients or with families basically that may have issues, poverty, you know, mental health, pretty much across the board, where you can identify mental health issues and perhaps get a mental health provider to work with these patients. So the social determinants of health is one means of actually addressing this. a very important factor. The chronic condition management, again, we see that as the future is going to be about managing diabetes before people get acutely ill. So here's one way to do it. Improve those care transitions so that you've got somebody watching out for these transitions in the home. Make sure that the medication is available. Make sure that the handoff between acute care and home care is done successfully. And address the needs of accountable care organization. I already talked about that as well. But be open to opportunities, but remember to start small and build the capacity before taking on too many things. This is one of the things that we're told happens too often. It's like we're going to do everything at once. And instead, the advice is, start small, get your data collection instruments in place, start thinking about the future of your financial sustainability, some of these things as well, but don't try to do it all at once. And again, use the wisdom of folks that have already done it, the tools and resources that may be out there, et cetera. So these were just some of the lessons learned that were expressed by our participants.
So some possible state flex program roles. As state flex programs, most of you are familiar. If you've been opted into the EMS program area, if you've been thinking about the EMS program area, this looks familiar to you. I'm not going to read it all. You can see it there. But technical assistance and consultation for implementing community paramedicine falls into activity 4.3, which is rural EMS operational improvement. But the reason I list it all out here is because I think, you can think about the other ways to support community paramedicine, like we talked about data about 64 times, right? So think about providing some education around using data, that would really do a CP program probably a world of good to support their educational needs around data. I know there are flex programs out there that are supporting the training of community paramedics and rural community EMS and all kinds of different titles. So there are different ways that community paramedicine could be supported by a flex program. In addition to the traditional supporting education or paying a consultant to help them implement a community paramedicine program. I've said this a few times now since the summit, like serving as a convener is one of the probably the biggest main things every flex program does. You become aware of an issue, there's a topic that you keep hearing about. So what do? You bring together stakeholders, people that know what the issues are and can talk to you about potential solutions, right? You bring those people that have skin in that game to the table, have some conversations and figure out what to do with it. I think Flex is so good at that. That's just traditionally what they've always done. And I think it's just a natural thing that they do, almost a reflex. And then from there, demonstration and pilot projects, tons of that has always gone on in the Flex program. Like that's also a lot of what Flex programs do. And you might try something and it doesn't work. That's fine. Figure out why it doesn't work or move on from it. I know a couple of years ago, there was probably 10 or 12 state flex programs working on CP in different capacities. And I don't know what that number is now, but I guarantee if I go and look at it compared to a couple of years when I was talking about it, some states have moved out of that and some states have moved into that. And there's different reasons for that. It didn't work or it did work. And now Flex doesn't need to support it anymore because it's moving along on its own. So, and then I already talked about supporting continuing education. See. We talked with this group a little bit about the future of CP, and the way we were talking about it really was kind of in the form of crystal balling, kind of thinking about what might happen, not necessarily things we know are going to happen, although some of this is happening. So if you think about artificial intelligence and machine learning, you may not know what it is. I don't exactly know what it is, and I don't want to talk about it like I know a little bit, just enough to not want to talk about it like I know anything. But artificial intelligence and machine learning, like that's already happening in healthcare. That's not something that's even new. And I don't know if you want to get into that or not, Terry. Like I said, not so much for me, but.
Yeah, I think there's applications here. We didn't go into a great deal of discussion on it, but we know that AI is going to increase its presence in healthcare in general. And there are applications in that community paramedicine, in that home setting as well.
Yeah, they're basically being used as decision support tools, is my understanding. And then telehealth as a standard component of EMS and CP work. This is definitely already starting to happen. I know I've had some outreach from flex programs about kind of trying to understand telehealth for EMS when there isn't reimbursement for them. So it is already something. Telehealth is becoming a standard component of EMS and can easily see that moving into CP work as well. And I mean, ET3 is progress, right? Emergency triage, treat, and transport. To me, it shows us that CMS is considering and piloting different ways of paying ambulance services. And there are COVID flexibilities in place for treatment in place. Those are things that it's pretty obvious the federal level, they're at least paying attention to that. And that's so much progress from the past where EMS and ambulance services were just transporters. They weren't considered providers at all. I just think there's a lot of progress happening with that. You know, we were considering whether reimbursement from multiple payers, regardless of transport status, was going to become a thing or not. There's some of that right now with COVID flexibility, but what happens after that? And then coding for social determinants of health. Terry mentioned social determinants of health earlier, and there is a project, it's included in the resources section of the guide. It's called Project Gravity, and it has to do with coding for social determinants of health, which right now isn't assigned to any one provider. No one's necessarily doing this as it is just dedicated to them. There are opportunities for this. So I mentioned a couple of times, there is a full summit summary document. It's called Implementing and Sustaining Rural Community Paramedicine. There's a link in the chat. We'll also be sending out an email announcement of it. It goes into much more detailed information than we were able to today. It has some examples of current models of community paramedicine, and there's a pretty sizable section of resources in different categories. And there is a link to the document right there. Just a couple of other related types of resources. The CP Impact Reference Guide, it actually says annual update to be released soon. It's on the website right now. I put it up just before this webinar, so you can click that link and check it out. That is a resource that we released last year, and now it has been updated to have 2021 citations in it. So it basically is highlighting work that has been done. So it's kind of basically evaluations. They're looking at projects that have been evaluated and the impact that they've had. So it is a great tool for folks that are considering community paramedicine, and it has columns where you can sort by the category. So it's a pretty cool resource. Check that out. And then also September 2021, so right at the end of the program year, we have another set of resources coming related to navigating rural EMS change. And that set of resources really is going to get into how ambulance services can figure out if their systems are effective, and moving into how to educate and communicate with the community to figure out how to move if their system isn't, if they're deeming it not effective and they want to figure out how to move into a different model. And that is it from Terry and I. If you have any questions about anything we talked about or anything you see in the guide, definitely feel free to shoot either one of us an email, or if you read something and you're wondering where that happened, definitely let us know. So with that, I'm going to end this part of the presentation, but Sarah Craig from the South Carolina Flex program took part in this summit, and you guys have heard her talk about community paramedicine in the past, but she's been doing it for years. So I just wanted to give Sarah a few minutes to kind of talk about what she would consider maybe best or promising practices and maybe lessons learned in her time of implementing community paramedicine programs in South Carolina.
Perfect. Nicole, how much time do I get? How much would you like me to leave for questions?
Oh, maybe 10 minutes. You could talk for about 10 minutes.
Okay, perfect.
Okay.
Well, I'm happy to be here. My name is Sarah Craig. I am the Director of Health System Innovation at the South Carolina Office of Rural Health. We have been working on the community paramedic model for almost 10 years. I think next year will be 10 years. So it's such a great model. It's definitely an EMS initiative that we really believe in and support across South Carolina. I cannot talk about all the work that we've done without recognizing Flex. We have focused on EMS since the inception of Flex, and it really helped when we started expanding outside of just that traditional support with EMS. So, you know, that funding via Flex for EMS is essential. So, you know, we are very grateful to the Federal Office for Health Policy for always including EMS in the opportunity areas for Flex. Our support, and I'm just going to talk about the state level work that we've done, and if I have time, kind of get more into like the EMS agency work around community paramedic. But initially, when we started building this model in South Carolina, we really had to engage our EMS state office and our, HHS office, the Nurses Association, and our committees for EMS, and, really start getting them to understand this model. When one of my biggest lesson learns was when I went to a meeting about CP and getting approval from the EMS regulatory body. They had already decided that anything I was going to say was an automatic no in the meeting. And I was so frustrated because I was like, this is such a great model. And, this is a great way for EMS to just really propel themselves more into the provider role and less as the transportation benefit, as our Medicaid office sees them. And, it was an automatic no. They didn't care what I had to say. So I always say you cannot make any changes until EMS and they're on your side and they feel like what you're bringing to the table is going to impact them positively. Our office is a nonprofit, so that really helped us in this whole community paramedic model, MIH model, because we were such a neutral party. We weren't a part of DHEC, we weren't part of the university, we were there just to support them. And so we had to reiterate that over and over again. We're a neutral party. We're here to support you guys. So that whole getting the EMS body on board probably took 3 years. In that time, we developed training guidelines, which include hours for anyone in South Carolina who's going to pursue the community paramedic designation for a paramedic. So it goes through kind of criteria that you have to pursue that designation, and then hours associated with that. And then it goes into areas of focus for both the didactic and clinical portions. So it comes out to 225 hours total. And that document was created through a committee that we had within an ad hoc committee that we chaired at our office. So it was the Community Paramedic Advisory Committee. So it was everyone interested in the community paramedic model, training institutions, and we had our surrounding states involved in that as well. So that final document, it definitely is not just based on our stuff in South Carolina. It was based on North Carolina, the APP model in North Carolina, the Hennepin model, and then some of the Colorado rural stuff as well. So that was very much a collaborative of what the needs were in South Carolina and then what others were doing. At the same time, we developed a metrics document. So anyone that was pursuing community paramedic had to collect certain data points so that we could have a minimum data set in South Carolina. And then the last one was protocols. So we have state protocols that dive through all all areas of interest that were currently pursued up to that point. So they also include pediatric protocols. So that, like I said, took about 3 years, and that was finally approved through the EMS body, and then other agencies could start pursuing CP. At that point, there was a delay in funding for grant programs just because there were the programs that initially were invested in this, they got a lot of the grant support in South Carolina from our philanthropic organizations. So there was a lull probably for 2 or 3 years, and then we started seeing agencies like, okay, I know this model, I've seen this model, I've heard my counterparts from other counties do successful patient navigation and patient support and patient education with these models. We're interested. So we had a state training agency decide that they wanted to invest and start training some students in South Carolina and then potentially expand nationally. So that was a huge incubator for RCPs in South Carolina. That was essential because it just allowed for that pipeline to continue in. So that was great. The next big thing was really getting that support from the directors and the community paramedics and connecting them. So, we did a lot of work trying to make sure that the programs that had been around for about 5 years, that they were really mentoring the new programs, because our office, we're not clinically trained. We just supported them with, program and initiative development and working with our state partners and, kind of that piece of things, and not necessarily, the nitty gritty with patient education. While we gave them resources and point them in the directions that they needed to go, we didn't really have that hands-on piece with, chronic disease management. So then now it brings us to more of what Nicole and Terry were talking about with, ET3 and telehealth and alternative destinations and treatment transport. We feel like all the work that we've done, that we've, paved the way with CP, has really allowed us to really expand those models with very little pushback from the regulatory body. They see all those as tiers to CP. So they feel like those are just enhancements and not necessarily an area that they want to really have very much control around. And it's so surprising because when we were going through with CP, they, everyone was extremely hesitant to why we needed training, why we needed data metrics, why we needed protocols, but that side of the fence. And then also the fence of, no, this is within the scope of practice, but no, we're not trying to do this. It was just all over the place. So it's nice to see that work has really had the medical directors and our bureau just not a ton of pushback. And, like Nicole said, COVID definitely has helped speed up some of the telehealth and alternative destinations entry in place. So that's been very helpful. For the agency, I'm right at, Nicole, do you want me to just briefly talk about the agency side of things?
Sure.
Okay. For the agency level, we developed a community paramedic blueprint, and that really breaks down, our first initial CP program, their experience. It goes into, national programs, what community paramedic, the definition of community paramedic, kind of what services a community paramedic provides, goes into how to conceptualize a CP program, identifying needs within the community, how to identify additional partners, outlining a program sustainability, and then it goes into, program branding, visits, patient engagement and patient satisfaction, discharge from a CP program evaluation. So we really developed that document to really help agencies, kind of break down the barriers and provide a step-by-step guide for them. And that has all the resources that we used in South Carolina, everything that they could rip off and duplicate, such as the home safety assessment. That documents in there. They could go in and adjust it to, add their logos and adjust it to their agency. So we always recommend that the CP programs focus on 4 areas when they're first starting off. So high utilizers for their EMS agency, COPD, asthma, diabetes, hypertension, and heart failure. Those are the 4 we always recommend. And we really feel like those really get at who they need to, within their agency, need to address before expanding out into the hospitals and primary care side of things. So that's where we initially start with them and just build a program from there. However, for all of our EMS agencies, they have to complete a community needs assessment before they actually start a CP program. So that really helps identify what is really going on in their community. And once they see that information, they have to do that both on the training side, and then they have to submit that to our EMS bureau. That really adjusts their programs as well. So I think I'm gonna stop there. It's definitely an ongoing support with them. And once you get past the barrier of EMS pushing back on the model, the new models, and or who are you kind of pushback, it really definitely begins to streamline.
Thank you, Sarah.
Yeah.
And that community health needs assessment was another point that was brought up a number of times with our participants. Like, it's so important. How are you going to decide what to start with if you don't have that community health needs assessment data? And it could be working with the local hospital to get in on theirs when they're doing it and really learn and not just guess and pick something out of the clear blue sky and start working on it. So that was an important point too. Thank you, Sarah.
Yeah.
Anybody else have anything they wanted to add to lessons learned implementing CP through Flex, or any questions for Sarah, Terry, or myself?
Hey, Nicole, this is Nita from Georgia.
Hey.
This has been wonderful. Thank you so much for pulling this together, and thank you, Sarah. Terry and Nicole, I do want to tell you that I may be able to help you out with some data. I am finally drawing to a close at the end of this month a 4-year study that I'm working on, specific to 6 rural community paramedicine programs in our state. We spent the first year framing it and getting protocols and equipment together, and then we've had 3 years of actual patient data collection. So I'd love to talk to you and Terry about this offhand or offline. We only, of course, it's rural, so we're probably only going to have about 150 patients total that have been enrolled. But from that 150, those 150 patients, we have collected a lot of different data and a lot of different types of data. We set this up so that we could look at the services being provided, and we divided this study into 3 different levels of service so we could see which is the more beneficial level or the more common level. We also have had an accounting firm heavily involved with us, as well as an attorney who specializes in EMS law to keep us legal, and of course, good medical direction as we've been moving through this. And some of the best information I think we're going to have is specific to all of the time on task that the community paramedic invests in those patients that is not direct patient contact. And when we started working with our Medicaid office about reimbursement, obviously they were looking at reimbursing that face time, that interaction time with the patient in 15-minute increments. But one of the things we're going to be able to show is how much time those community paramedics have to invest in the administrative end, and that it's not a black and white bill for a 15-minute interaction with the patient, because the cost of the service is much more than just what they can collect or cover through that 15-minute or 30-minute reimbursement. But we have invested during these 4 years over $1 million into this particular grant program. And so we're going to start pulling the data together this summer and deciding how we can compile and then complete the report and make it public. But I would like to talk to you and Terry at some point about what we've done and what we're collecting and what we've seen so far.
That'd be great. We'd like
Oh my gosh, I would love that to be a webinar.
Yeah, that's absolutely terrific, Nita. You know, we went into this, I think, kind of it seemed like a great idea, but boy, the more we got into, at least for me, I really think this is going to be a significant part of our future healthcare system. And I think it's so great. I've got an EMS background. I think it's so great for just emergency medical services because it's going to, that has been so separate for so long. It's going to kind of suck it into the entire healthcare delivery system, and EMS is going to play an even more vital role than it has in the past.
I think you're very right. And I think what the community paramedicine programs in the urban areas are much different than those in the rural areas. And Sarah, don't think you're off the hook. I'll be reaching out to you too, because I've got some more information I'd like to collect from you and compare notes before we start putting our data and final report together.
Absolutely. And we're doing an impact study of our active programs too. So that would be great to pick your brain before we start that evaluation.
I will connect you two unless you're already connected.
Oh yeah, I know Nita. Yeah.
Okay,
yeah.
Great. Okay, well, we are out of time. Obviously, we could talk about this for much longer today, but I hope you heard something that was relevant to what's going on in your communities or what you're thinking about for your Flex program. I put my email address there in the chat. 95% of you know where to get a hold of me, but I see some names I don't know. So if you have any questions, want access to the document or whatever it is, feel free to send me an email. I'm happy to have a follow-up conversation with you or point you in the right direction. So thank you very much, Terry. Thank you, Sarah. Thank you all for coming and have a great day.
Bye, everyone.
Bye.